hypomyelinating leukodystrophy. At that point of time, when we went to publish this case, the entire literature, though there are not many, the entire literature was supportive of a maturation delay in hypomyelinating leukodystrophy, and that too only a first peak. There were no other peaks, and consistently there were 3 to 4 studies which had reported only first peak. Nowhere was auditory maturation delay noted or even reported. So this was the first case which we reported previously. And a progression from ANSD to maturation delay is what we speculated. We thought that any children, or at least a group of children with hypomyelinating leukodystrophy, might have ANSD. Probably, if you see, most of these evaluations are done in neurological setup where they don't follow this protocol, what we say rare fraction and condensation for seeing cochlear microphonics, right? So we presume that one factor could be the recording parameters. The other factor could be the age at which the testing is done. So if the child was tested just at the age of 1.5 years or 2 years when the symptoms just started, probably at least a section of children might be auditory neuropathy spectrum disorder, and it could be a transient episode and they become auditory maturation delay over a period of time. So that is what we thought. So with this experience with one of the previous case studies, we thought that if you go back and see the waveform here, if you could see this waveform here, there was some amount of cochlear microphonics on the right side. Is it visible for everyone? I hope. If not, I'll just clarify towards. There is some amount of cochlear microphonics which is seen here, after which you are getting your first peak. So even then, that was something which was very interesting for us, because of which we decided to probe this further. And what we thought is, how else can we stimulate this auditory nerve, or how else can we make sure whether this auditory nerve is functioning properly. So when we started giving stimulus at a higher rate, 91.9, your first peaks completely disappeared, and what we got was very surprising. It was a complete reversal of the peaks. It was a auditory neuropathy, cochlear microphonics. We did tube press, we did without stimulus. This is not an artifact. We confirmed it. We did the AB minus rare fraction condensation, subtraction, everything, and this is an authentic cochlear microphonics which we got at 91.9 milliseconds. Then what we did is we just thought, is this only at very high rate, and we thought let's do at something which is just in the upper segment of what we do, 11.1, which generally we considered for 11.1 to 31.1. when we are doing pediatric ABS, we generally consider it to be normal. So when we did that, even at 29.1, what we observed was the nerve was not functioning normally. The nerve was not able to take this faster rate of stimulus, and the dysynchronous component was pitching in, right? So this was something which was very unique for us, probably which might be case in many of the auditory maturation delays secondary to underlying neurological condition like hypomyelinating leukodystrophy. So this is something I'll just skip. Conclusion. The literature has always said about the first peak, and when you increase the click rates, or when we move to the higher rate, what happens is generally your ABRs disappear, or the first peak's amplitude disappear, or latency shift. But at 91.1, if it is a maturation delay, most of the time your ABRs disappear. Nowhere is it reported that your auditory cochlear microphonics might be seen and only your first peak will be disappearing. So what we concluded with that, this case, or our observation was, high rate ABR in maturation delay may be an effective tool to identify a variant of ANSD. Now these children, when we take them for granted auditory maturation delay, again we have seen some children with maturation delay show consistent responses, some show inconsistent responses, right? This information of how high rate ABR, if I'm saying again, I'm stressing on that word, if an high rate ABR can differentiate or can give you an information that a child with auditory maturation delay can have ANSD also, or an underlying auditory neuropathy, or even if we don't want to call it auditory neuropathy, still and dysynchronous firing at even a slighter higher rate, probably that should be called a variant of ANSD, because as we know that ANSD is something, it's a spectrum of disorder. We keep evolving every day. We keep adding cases to that. We are seeing variants every day. We are learning every day. So this could be one of the variant, and I thought that this could prove to be a very effective clinical tool. And I mean, this is in the process of publication. We have 3 cases similar to this, and we are in the process of publication. And, yeah, I think this is what I wanted to convey through this case, how important your high rate ABRs are. And most of the time it is argued, or generally it is the high rate ABRs are generally taken for granted that it is only for retrocochlear pathology, or clinical utility of high rate ABRs are not to the extent of what it is thought. But again, in clinics, if you start applying your mind and if you start using it on cases where you start observing this minute observation, had we not seen that cochlear microphonics at the initial 0.5 to 1 milliseconds in the ABRs, where I showed you at 11.1, probably I might have not done this high rate ABR. But now that we did, and we are in the process of changing a protocol that we should be doing high rate ABR for all maturation delayed children. And maybe this, to the best of my knowledge, would be the first report, and we are in the process of publication. And we have sent the draft. We are waiting for the communication from the other side.
Thank you so much, Pradeep. That was a very excellent, apt presentation. Sorry, did you say something?
I'm on time.
Oh yeah, perfect. Yeah, thank you so much.
Okay.
I didn't
want to cluster it too much. I just wanted to stress on importance of high rate, how this could prove a clinical tool to extract a variant of ANSD, and in maturation delay, where generally because of the definition of auditory neuropathy spectrum disorder, where we say it is abnormal ABR or abnormal fifth peak. So probably I am planning to add up even first peak to that definition coming days if possible.
Absolutely. No, I think it was a very apt presentation, and I think the points that you've mentioned are very relevant, and I'm sure that a lot of people will learn a lot from this, and I'm sure there'll be a lot of questions around this as well. Especially maturation delay is always a topic of hot discussion. With that being said, without much ado, let me introduce our next guest speaker today. His name is Dr. Shreyank Swamy, and he is presenting an interesting case of mitochondrial disorder to us. And he is an academic, and he teaches at a university. And I'm sure that he has something really interesting for us packed in as well. Over to you, Dr. Shreyank.
Thank you, sir, for your kind words. Is my screen visible?
Yes, visible.
Good afternoon, everyone. Without taking much time, I'll start with my presentation. And thank you for Pradeep, sir, because his presentation will be as a base for this case presentation in terms of maturation. So I'll be sharing about audiological findings in a 7-year-old child, which was referred by the pediatrician for the audiology assessment. The presenting complaint was delayed developmental milestones with a positive family history, and the high risk factors identified were elderly pregnancy at the age of 37 years and late preterm, and no other pre, peri, or postnatal risk factors was reported. And the medical diagnosis made by the pediatrician was global developmental delay with microcephalus. On audiological findings, the child was not, as there was a delay in developmental milestones, the child had recently achieved head control, and sitting with support was achieved. However, the child was not cooperative to wear headphones, as she had got weakness in her motor ability, but still she was able to do some tasks like holding the rings or transferring the toys. So the Puton audiometry results was indicated 40 to 50 dB HL thresholds, where it was an inconsistent response, and it was presented through loudspeaker since the child was not cooperative to wear headphones. And on impedance audiometry, it was AS type on right ear and A type on left ear, with presence of ipsilateral reflexes at 500, 1000 and 2000 Hertz. And otoacoustic emission TOEs were absent in both ears, whereas DPOEs were present in both the ears. The TOEs were absent as the child had noisy breathing, as the OEs were recorded during the time of sleep on sedation. So since the child had inconsistent response to the Puton thresholds, we planned for an Abr threshold estimation using the following protocol. On Abr threshold estimation, we identified there was a difference or delay in peaks of 2, 3, and 5 in both the ears, and it was consistent to rule out cochlear microphonics, as I've highlighted in the yellow shade at the bottom of the screen. So it was ruled out where cochlear microphonics were present only within 1.5 millisecond in both the ears. And all the three polarities were performed to identify the peaks accurately. However, the fifth peak was not, the morphology was very poor. Further on, with the decrease in intensity, the peaks were present, all three main important peaks were present till 30 dB NHL. So, dear participants, based on this findings, where there is a delay in third and fifth peak, and there's a and good morphology of 1, 2, and 3. So what could be the possible underlying pathology? There is a polling, which there is a link will be shared on the chat screen. Kindly answer those polling so that we can move ahead after the polling session. So based on the ABR findings, kindly tell us what could be the underlying pathology, whether it is auditory maturation delay, transient ANSD, neoplasm, or it could be any other possible factors. Imran sir, can you share the link which was sent?
It is shared, Shreyank.
Okay, thank you, ma'am.
The link is in the chat box for everyone. If you can just click on the link and just put your responses in, that will be great.
So already we have receiving the responses. So right now the majority is for auditory maturation delay and neoplasm. We'll wait for another few seconds and then we'll get back to the presentation. Well, let's get back to the presentation with the response more for auditory maturation delay. So based on these our audiological findings, even initially we felt there is a auditory maturation delay. However, based on the findings, we made an impression for the neurologist saying that 1 and 2 peak latencies are within normal limits, which is indicative of peripheral auditory nerve intact, and 3 and 5 peak latencies are prolonged, which is indicative of brainstem abnormalities. However, this impression was not made on the same day of examination, as we were not aware, because it was difficult for us to initially mark 1, 2, and 3, because we had a confusion between 2, 3, and whether it is 2 is 3 or it is actually second waveform. So then we probed into medical information. Then they said there is an MRI which has been done. So we waited for the MRI report till we made the diagnosis. So as we received the MRI report, which was done using a technique called sagittal T1, T2 and axial T1, T2 weighted images of the brain, which was studied and correlated with coronal flare images. And the impression made by the neurologist was bilateral symmetrical, radiologist was symmetrical altered signal intensity at putamen, both cerebral peduncles, dorsal aspect of the pons, and medulla, which was suggestive of mitochondrial disorder, that is leak syndrome. So since our ABR findings were correlated with MRI reports, as the 8th nuclei and other nuclei, that is which is mainly important for the peaks of 3, 4, and 5, which are present between pons and medulla oblongata. So the MRI and ABR reports were correlated. Moving on to the leak syndrome, a brief about the leak. It was initially Danish League, a British neuropathologist, in a 7-month infant on post-mortem identified that this condition, where the pathophysiologies are subacute necrotizing encephalomyelopathy, heterogeneous disorder due to abnormal mitochondrial function, and it is a progressive neurometabolic disorder of infancy and childhood. And the incidence rate is 1 in 40,000 births and 1 in 2,000 births in isolated population near Quebec and Canada, and 1 in 2,500 in Faroes population. And also in Northern Europe, the study reports in the preschool children, where it can be seen in 1 in 32,000 children. The onset of the condition is early, and it is a neurodegenerative disorder, and it has got wide age range of disease onset, which can be in utero with oligohydramnios and intrauterine growth restriction. And it can typically between 3 months and 12 months of age, this can be identified, or the onset is seen with a seizure, and it may not be clinically observable until second or third decade of life. If in case the onset is during the first year, then complaint of loss of head control and motor milestones will be reported by parents. As this is a progressive in nature, it can lead to any untimely death. So the encephalopathy, it can lead to the medical problems which are mentioned here. In addition to that, it can also lead to delayed developmental milestones of speech, language, and motor, and hearing loss, as well as cognitive decline. The diagnosis can be made in such case by genetic evaluation to identify the type of mitochondrial DNA mutation, and by MRI, autopsy, and other clinical findings. The treatment options depends on genetic evaluation based on the whole exome sequencing, and as a placebo, they even gave administer mitochondrial cocktail. In literature, in leak syndrome, audiological findings have been reported where prolonged interpeak latencies have been reported between 1 and 5, absent wave 5, and completely absent ABR also. Kaga et al. Also reported the presence of wave 1 and absence of wave 5 in 3 children ranged between 8 years to 15 years, 9 months. It can indicate of cortical form of leak syndrome, whereas Yuvraj et al. Reported transient form of ANSD in a 2.8-year-old, and also Yoshinaga et al. Reported that the ABR can be used to identify the leak syndrome, because in early stages before the presence of any clinical symptoms, the ABR abnormalities can be seen, and also if there is any improvement in the medication or in the condition, it can be first seen in ABR compared to MRI scan. So as a take-home message, the prolonged wave file latency in case of global developmental delay or developmental delay requires a referral to a neurologist or pediatrician, because sometimes we do neglect, because as the child age was 1.7 years, we may say because of the developmental delay, still the auditory brainstem is still maturing. So we keep following them after 3 months or 6 months or so on in a periodic manner. However, say, conditions like this where a mitochondrial disorder can be placed, where we should rule out any other presence of any syndromic cases, so that first referral to neurologist and pediatrician should be made in case we come across any developmental delay. And also in syndromic cases, regular follow-up or evaluations are essential, as we understood that based on the literature, they says that the prognosis can be first seen in ABR compared to MRI. So thank you, everyone.
Thank you so much, Dr. Shreyank. That was a very interesting case, of course. And apologies in advance. I did not know that you wanted to keep things as a suspense. I did reveal that it was a mitochondrial disorder in the beginning. But regardless, I think it was a very interesting case. And listening to this case, and of course what Dr. Pradeep presented before, it just reminds me of how important it is to remind ourselves as audiologists that we are not just technicians following protocols and processes, but we are actually clinicians who can adapt and modify these protocols to reach to a certain diagnosis in situations where things like these occur, where things are out of the normal, and you went ahead and you probed further, and then you understood the whole diagnosis. And of course, in the process, you would have helped the family and the patient as well. So very, very, very good case. Thank you so much to share that with us. Yeah, if you guys have any questions for Dr. Shreyank, please put them in the chat box. Like I said, refer the question to him so we know who the question is for. Without a further ado, let me introduce our next speaker for today. And our next speaker for today is Dr. Sandeep. We all know him. He is actually the brains behind this webinar as well. He is the one who actually suggested us that something like this could actually happen, and it could interest a lot of us. So immensely thankful to him for this idea. I think it's a brilliant plan, and I think it's working out very well, up till now. So we all know Dr. Sandeep. I don't have to introduce him too much, but he is one of the best that we have in the field of audiology in India, and of course, I would say globally. So he's going to, I'm sure he's going to present a very unique and interesting case for all of us. So I won't reveal any suspense. With that being said, over to you, Dr. Sandeep. Sir, over to you, sir. You can proceed with the talk.
Yep. Good afternoon, everyone. For courtesy's sake, it's a formality to say some kind words when you introduce a speaker. So don't take those words very seriously, whatever Imran told. It's very easy to suggest something, but to take it forward, to take the idea forward and make it happen at the end of the day is something really appreciable. And I think Dr. Imran and Dr. Srividya both have done a wonderful job organizing this webinar. This is basically a medical model. We wanted the speech and hearing fraternity to realize, particularly the audiological fraternity, to realize that on a daily basis, we are seeing very interesting cases, if and only if we are interested to see that uniqueness in each case. Okay, so this is one such case wherein we were posed with a challenge, and while actually troubleshooting, we actually explored something very new. So this is the case history. It was a 16-year-old female. She hailed from Bihar. She had gone to several places before coming to ISHA, but somehow they had not got a very convincing answer for their questions. So they visited ISHA. The complaint was hearing loss in both ears since 2 years, and hearing loss was progressing. Tinnitus was there at the beginning, before probably they realized that they are developing hearing loss. But once hearing loss had increased, tinnitus disappeared according to whatever they reported. There was poor speech perception. The patient as well as the caregiver was saying that she's able to hear, but then not able to understand speech. When we did audiogram, this was the audiogram. So you can see that, one second. Yeah, you can see that the responses are present in the right ear only for low frequencies and absent for the high frequencies. And this was the response in the left ear. When we actually looked at on the right side, we thought it's a dead region of the cochlea with inner hazel damage. This is the PTA. So right showed profound hearing loss, left showed severe hearing loss. We were not able to estimate SRT and SIS. So we did SDT, and this is the SDT. Tympanometry showed A-type tympanogram in both ears with reflexes absent as expected because of the severe to profound degree of hearing loss. We did otoacoustic emissions. Otoacoustic emissions were present in both ears. This is where we actually encountered a challenge while recording otoacoustic emissions. I'll come to that later, but we troubleshooted and we kind of designed different strategies to record otoacoustic emissions. And finally, we were successfully able to record otoacoustic emissions. OEs were present in both ears, indicating normal outer hazel function. So we thought probably, yes, there is damage in the inner hazels with spared outer hazels, and that kind of strengthened our notion of dead regions of cochlea. We recorded auditory brainstem responses. Owing to the severe and profound degree of hearing loss, auditory brainstem responses were absent in both ears. So what is that interesting issue that happened while recording otoacoustic emissions? So when the audiologists went to record otoacoustic emissions, they were able to successfully record otoacoustic emissions in the left ear, but they were not able to record otoacoustic emissions in the right ear. What was the problem? It was showing noisy in an audiometric room where we were successfully able to record OEs from the other ear. So for the same level of noise in the same test environment, we were not able to record otoacoustic emissions in the right ear. Now, what could be the possibility? We thought probably there is objective tinnitus. There is some noise that is getting generated within the ear. The possibilities: one, before we actually looked into the possibility, we wanted to ensure that there is objective tinnitus. So the first thing that we did is we kept our ear close to the patient's right ear and tried to listen whether any tinnitus is heard, to say it's an objective tinnitus. When we made that attempt, it was very feeble, so we were not able to hear very clearly. So what we did is we took a stet. Okay, we took a stet which we use for hearing aids to listen to the output of the hearing aids, and we put this stet tube into the ear canal of the right ear, and we heard what is in the ear canal, and we could hear a significantly loud pulsating sound. Okay, significantly loud pulsating sound. So this is what we saw in otoacoustic emission recording. Please note, this is OE being recorded in the right ear, and this indicates the noise floor. And you can see the noise floor is fluctuating intermittently. So it's not something that is continuous, it is intermittent. And this is why we were not able to record otoacoustic emissions. Now, obviously, when we record otoacoustic emissions in the clinic, in an adult, we record when they are in the erect position. We made an attempt to record in the erect position, and we were not able to record in the erect position at all because this noise was very disturbing, and we were not able to proceed with the OE recording at all. Now, in this case, we have tried to place the patient in the supine position, not completely supine. It's almost like a 45-degree angle on a reclining chair. And we were able to successfully record otoacoustic emission to some extent. And then we actually put her to completely supine position. We were able to record OEs in a much better way. So that's how we troubleshoot it. So what is the source? So this is basically indicating that there is some noise that is getting generated within the ear. So what is the possibility? So what special test do I do to identify this source of sound? Two possibilities that we knew were, one, petilous eustachian tube. So it's a chronic condition, as you all know. Eustachian tube is always open. So when we breathe in and breathe out, the air gets into the middle ear and gets out of the middle ear. That respiratory noise can be actually picked up by the OE microphone, and that in turn can interfere with the OE record. So we did the special test that we do in the tympanometry, where we go to reflex decay mode and ask the patient to do three things. Once, hold the breath for 10 seconds and we record the reflex decay. And then we ask the person to breathe normally and we monitor the admittance over time. And then we ask the person to breathe deep, breathe in and breathe out deep. And while the person is doing that, we record admittance over time. And if it is petilous eustachian tube, you will see that there will be a huge variations in the admittance. There will be a huge variations in the admittance like this, indicative or supportive, suggestive of the petilous eustachian tube. But what we noticed was not that. There was no such variations with different breathing patterns, irrespective of the breathing pattern, irrespective of whether the person is breathing or not, or holding the breath. There were few perturbations, but that was not coinciding with the breath rate. So second possibility is it could be a tumor. Usually the first one that we think of is glomus jugular tumor, which is in the middle ear. If it impinges on the ossicular chain or on the tympanic membrane, then it can vary the admittance whenever the blood gets in and gets out of the tumor. It can vary the admittance and you will see perturbations equal to the pulse rate of the person. The other possibility is there could be brainstem tumors. If there are large brainstem tumors, there could be perturbations and that noise of the circulation, blood circulation, because tumors are generally highly vascular. So when the blood gets into the tumor, gets out of the tumor, the gushing of the blood can actually be picked up by the noise that gets generated by the gushing of the blood into the tumor and out of the tumor, can be actually picked up by the microphone of the otoacoustic emissions. So what we did is we suspected a tumor and sent them to a neurologist. Neurologist advised for an MRI, and you can actually see that there is a huge tumor here. So this was a 16-year-old female, had severe to profound hearing loss. Coincidentally, we were not able to record otoacoustic emissions in 1 year. While troubleshooting, we detected a brainstem tumor. What is the source of noise? As I said, the possibility is the circulation noise. I have a video here, which this is a talk by Hudspeth. He's a genius person, has done an extensive work in cochlear physiology, more in terms of the physiology of the sensory cells and stereocilia. So in this lecture of Hudspeth, he actually plays this video of OEs being recorded. You can actually hear the circulation noise and the heartbeat when the OEs are being recorded. Please listen to this carefully.
You will hear two emissions at high frequencies coming from a normal human ear. You may also be able to discern background noise like the microphone chips, breathing, stomach, heartbeat, the vessel is closed.
I think it's finished, sir.
Yeah. So that's the noise probably that is getting picked up by the sensitive microphone that we use for the recording of photoacoustic emissions. Okay, so that's it from my side. So I just wanted to share my experience. Just wanted to share my experience with this case in this platform. That's all.
Thank
Imran.
you so much, Sandeep, sir. I think this again goes back to the same point as, I've mentioned earlier. I think we are so used to being just technicians, we forget that our job as clinicians is so crucial to help so many patients. And in this case, it was, so unique, like where you could find out because of the noisy autoacoustic emissions, it could easily been diagnosed as an absent autoacoustic emission for a technical issue or something like that, or we could have left the case at that, just assuming that it was a profound hearing loss, or 100 things could have happened, but we still probed further. We still helped the patient, and we're able to diagnose some condition where I'm sure that he or she will get relief from it in her or his lifetime. So I think it's a very, very crucial role that we play as audiologists. So thank you so much for presenting this very unique case. I'm very sure that we've learned a lot, and I'm very sure that we are already getting a lot of questions. But keep your questions coming. Please address it to the speaker that you want to address it to, so we know whom to ask. We will definitely come to it at the end of the webinar. And without further ado, let me introduce our next speaker, Dr. Chandan Saha. Dr. Chandan Saha, again, needs no introduction. He is actually one of the pioneering audiologists in cochlear implant audiology that I know of. When I was studying, he and Saji were pretty much the champions of cochlear implant audiology. And then I'm sure he's done a lot of clinical work after that in different fields. And he's just a brilliant person to talk to and learn from. I'm very sure that he has something very interesting and clinically, apt to talk to us today. And it's really a pleasure to have you on board, Dr. Chandan. I think it's been a long time that I have learned from you. So this is again an opportunity for me. I've learned a lot from you in the past, and this is again an opportunity for me to learn from you. Over to you, Chandan sir.
Hi Imran, I just copied Sandeep's words of about an introduction. Okay, but you ate up on quite some time from my presentation. I will start going for it immediately. So my presentation is mainly focused on what to do after we have diagnosed an ANSD. So we have talked a lot about how an ANSD to be diagnosed and how we can find out, differentiate it from maturation delay and other things. So in an ANSD, is a hearing aid trial a waste of time? Because this has come up because of certain popular beliefs that I have come across in different platforms. And these are the popular things. So hearing aids have got limited role. It improves detection, but not discrimination. And some people also believe that it destroys the residual because after using hearing aids for some time, the OA is disappearing. So I don't know what good OAs are if a person is not hearing anyway. Need very high quality hearing aids, that is maximum number of channels are needed for the hearing aid to be of some help. Now, these are very popular and to an extent quite established beliefs in the field. So I just wanted to throw some light on based on my personal experiences, and I put that as a disclaimer that this is purely my own experiences and definitely supported by literature and interaction with other people. So I'll be talking about certain cases where I got good results. So I don't want to make it sound a biased certification as when I'm not talking about the cases where I did not get success. But I wanted to highlight on the managements that have made me successful or made my efforts successful. These are certain cases, the names are not to remind me on all these pet names for these patients. So you see, all of them are children, and their audiogram profiles are over here. Now, one thing that is important that I want to show is the measurements. I'm not profiling. The moment they are diagnosed as ASD, that means that areas were absent, OEs were strongly present, and in many cases, cochlear microphonics were present. Now, purely from the management of view, what was important for me was the SNR improvement. That is, SNR improvement with and without any management option, like whether it can be a hearing aid, it can be a cochlear implantary hearing aid, it can be an aid, anything. These are the basic things that we use for ANS. And you see here, in most of these cases, in all these cases, I have got quite good SNR improvement. Okay. Now, this child and this child were till the age of 4 or 5, they did not 5 years, they did not have any auditory symptoms. They were considered just like normal hearing children, and they started showing up.
Sir, can you
Yeah,
maximize your screen?
maximize my screen. It is on
F5.
Dr. Chandan, it is not the screen you're sharing. The screen share, that slideshow is not screen, is not shared. Just check.
F5. If I say it is function F5, has it gone? Or maybe
No, the share screen option, no, the particular screen you're sharing.
okay. I probably yeah. I was sharing a different screen. Now is that big?
Yes. Now it's fine.
Okay. Now all I was talking about is these two children were like typically normal hearing children till 5 years of age, and only after that they started showing problems with their hearing. And from the school, it was identified and they were sent. And after that, they followed the detailed evaluation, and it came out to be a auditory dysynchrony. And then we started working on how to improve the SNR. And in all these cases I have put on here is these are the modalities which have given me success. Now, you see hearing aid, cochlear implant plus hearing aid, hearing aid with ALD, and hearing aids. Now, here I have highlighted all these cases showing use of all the three components that are believed to be. And we have got mostly good SNR improvement in all these cases. Now, highlighting on one of these cases about their findings is Master Abr, who had a global development delay, believed to be a learning disability, and with behavioral issues. He attended special school right from the second year of age because of the global development delay, and the focus was moved on motor development, and developed age-appropriate language till 6 years of age. No questions about the hearing till then. And at the age of 3, there were, because of the motor development delays, a MRI was done, and periventricular leukomalacia in the right frontoparietal region were reported, with bilateral retino-optic pathway dysfunction was reported. But symptoms started showing up at 7 years of age, when first was decreased vision, decreased field of vision rather, and then burning of eyes and asking for repetitions. This is when they started, we started doing the audiological evaluation. And over this, since 2018 to 2020, mid of this lockdown period, the hearing as well as the visual acuity reduced drastically. Presently, he has 100% visual impairment, severely tunnel vision. He can see only about 1.5 feet distance, and he presently uses Braille for studying. And mild to moderate sensory neural hearing loss, typically an ANSD feature. Without any aids, his SNR requirement is plus 10 dB to even get to 85 dB, 85% of discrimination. Now, how do I do this trials on this patient? Is first find or estimate behavior observation or behavioral detection thresholds, then check for the uncomfortable levels, use NAL NL2 prescriptive formulas, cut low frequency amplifications till 1 kHz by 6 dB, and then I give two options. One is 6 dB increase at the higher frequency, and one is a zero increase. So one is with increment and another is without increment, and check for the recognition score, identification score, or in case of a non-verbal child, a therapist feedback. Now, frequency compression is deactivated, and I proceed with the trials only if the child or this person shows compliance with the hearing aid and has doesn't show any discomfort level. So, like last week when I fitted a child with a more severe degree of hearing loss, I fitted with the powerful hearing aids, and I kept giving loud sounds. The child started turning, but did not show a single sign of discomfort, was there in the clinic for 1.5 hours without touching the hearing aids. So this is a child whom I would go ahead with the trial, and I would extend this trial for next 2 months time before before prescribing the hearing aid permanently. Now, I was talking about here. I was talking about different ALDs as well. So the ALDs that I use and find very useful in such cases is a resound multimind using 2.4 gigahertz wireless. This is the picture of it. And R-tone neck loop. Not all hearing aids are 2.4 gigahertz compatible, and not all my clientele can afford very good hearing aids. But then my understanding is a moderate level hearing aid is as good as a high-end hearing aid in such cases. As long as I can keep the distance of the microphone pickup least from the speaker, that is the travel time of the signal or the traveling distance of the signal as low as possible. This is the target. So ALDs are the best bet to it. And when it is like online, a direct connectivity is the best thing. So I use a 2.4 gigahertz, that is resound multimic, or an R-tone neck loop. This is basically a telecoil, strong telecoil loop with an amplifier boosting the higher and the lower frequencies. This can be connected to a normal Bluetooth microphone, or a Bluetooth transmitter with an additional microphone, which is readily available online. And another ALD is a smartphone app. This one is the app that I use. There are 3-4 apps. This is a representation of it, and even iPhone Live Listen. Okay, now this is again based on my experience. The best one is the resound multimic. Second is R-tone with a Bluetooth microphone. And if I cannot afford anything, then a smartphone app, smartphone with app. So cost wise, this one costs about 19,000. This one together costs about 12,000. The microphone as well as the neck loop, and this costs 0. You just require a fairly good, about 10,000 rupees smartphone. And iPhone, I don't have an idea, but probably 25, 30. Okay, so not that we require very costly ALDs to work. Now, my learning, or what the points that I want to highlight from this experience is, being consistent is more important than being a pioneer. I do not want to say that, oh, this is an AI, so hearing aids will not work. Let's go to cochlear implant immediately. Every child who has a hearing issue, my first line of action would be an amplification. It does not cost much to try out things. So clinical work does not need always to be novel. It's an application of old proven theoretical evidence. So it has to be a proven and solid clinical evidence should be there to try it. 1 in 100 chances of success is 100% success for that 1%. Now, I picked up all these cases. There are many more children who can fit into such similar profile, but then these children are the one who keep thanking me for the chance that I took. So that is why this line has come. 1 in 100 chances of success is 100% success for that 1%. Now, always take chances if that causes no harm in doing that, and leave no stone unturned till you find the key. Now, I have found a strong, this is again my personal experience about success with acquired ANSD versus congenital ANSD. I have never had such good experience with acquired ANSDs. But with congenital ANSDs, definitely the success rates are much higher, and we must give them this chance with a hearing aid. And ALDs, as I suggested, must be used, and ALDs do not always cost very high. And as you saw, these ALDs actually uses something similar to what I am right now using, a Bluetooth neckband and the free app that I developed. So his cost was about 2,200 rupees. I also did a molding for his earbuds with a vent, and that helps him to keep it steady in the ears without causing a occlusion. So my highlight was that it's not always cost, it's not always hi-fi technology. Consistent use of time-tested tools can give you good results. And I thank ISHA for holding this platform and giving me a chance to speak. Thank you, ma'am.
Thank you, Dr. Saha, for such a interesting presentation. I'm sure there's a lot of things to learn from that. It's really liked the statement you made that even if it's 1 in 100 chance that somebody is getting benefit, that's 100% for one person. So I'm very sure that there's a lot of learning from that in the real world. And all the clinicians out there will definitely learn a lot from this. And keep your questions coming, please. Address it to the speaker that you want to ask the question. Without further ado, let me introduce the next speaker for today. She is a well-known academic and respected professional in our field, Dr. Vanaja. Vanaja ma'am, as we all know, she is one of the pioneers of diagnostic audiology work. She's taught a lot of us, and she's an inspiration to a lot of us as well. Like, words are not enough for me to be able to even express how much admiration we all have for her, as students or colleagues or fellow professionals. But I'm very sure that she has something really interesting and unique for us to learn from today. So over to you, Vanaja ma'am.
Thank you, Imran, for your nice introduction. And I quote Sandeep and Chandan about the comments on introduction. I don't really have something very, very new topic, but it's just like learning from each case what we can do.
Slideshow.
Slideshow. This is about a 20-year-old girl who was referred to me by an otolaryngologist. And otolaryngologist told me over phone saying, this girl has low frequency hearing loss, more loss at low frequencies, and she has very poor speech discrimination. So can you check what needs to be done? So obviously, I'm sure all of you know a 20-year-old girl in India, especially, we do see a lot of cases with ANSD in second decade. So 20-year-old referred with a poor speech discrimination, and then that question was also saying she's not benefiting from hearing aid. What do we do with her? So we said, okay, you refer, we'll do the detailed evaluation. And of course, our first suspicion was auditory neuropathy spectrum disorder. So when she I just want to say here that she came to us only for consultation. She is a resident of Mumbai. She came to Pune only for consultation. So I do have some tests being done in our center and some were done elsewhere. Okay. And when we took a detailed case history, it was history of hearing loss in right ear since about 1.5 years. And then it started in the left ear also. And of course, she said the problem is more in right ear compared to left ear. And her major difficulty was understanding speech. She says, I can hear, but I cannot understand speech. 20-year-old, she was going to college. So she did have a lot of difficulties in college, like almost like does not want to go to college because they don't really follow anything over there. And the difficulty was greater in presence of noise. And she also reported that her problem is fluctuating to the extent his mother was saying, sometimes, some days in the morning, she'll be hearing well, she can understand whatever I say, and then suddenly after some time, she's not understanding anything. And she did complain of vertigo also since 1.5 years, and she has tinnitus, and she does have intolerance to sounds. And she was tested by multiple people before she came to our center. This is a summary of the previous consultation she had before she came to us. So you can see that basically the right ear has always been moderate SN hearing loss, sometimes maybe moderately severe, but left is varying between minimal, mild, moderate, mild, moderate. And this I wouldn't say is only the differences because it was also not all testings were done in the same center. Sometimes it was same center, sometimes it is different centers. But I don't think it is related to the center or the audiometer calibration. It is her problem, I think, because the parents also say that the hearing loss is her problem is fluctuating. And they had got a CT MRI results, everything was normal. So we did start with a normal routine test like audiogram. So the audiogram showed a moderately severe SN loss in the right ear and moderate SN loss in the left ear. And her speech reception threshold was 70 and 55 dB. Word recognition score was 44% in right ear and 56% in the left ear. And her uncomfortable level was around 95 dB in both ears. And like I said, we always first think of auditory neuropathy spectrum disorder. To rule out that, first we did otoacoustic emissions. Otoacoustic emissions were absent in both ears. Emittance evaluation showed A-type tympanogram and reflexes absent. And auditory brainstem responses, we could identify all the peaks and absolute latency, interpeak latency difference, interoral latency difference were within normal limits. And when the repetition rate was increased with like a 90.1, the shift in latency was within acceptable limits. In essence, I can say ABR indicated that there is no retrocochlear pathology. So we did try electrocochleography with tipped-rod electrodes, and in the right ear, we could not record summating potentials, and in the left ear, summating potential action potential ratio was 0.54. She did complain of vestibular problem. So, but unfortunately, what happened was when they spoke to me over phone and referred the case, they did not talk of the vestibular problem. Their main concern was only poor speech understanding. So I had not given any specific instruction about not taking medicines for vertigo. But then when they came to me, they said that they'd already taken Vertin and Diamox in the morning, but the mother wanted the test to be done. So we just did it like a screening thing, all the tests, but everything showed negative. But obviously I cannot go by these results. She was referred to, advised to undergo vestibular evaluation once again. So now my question with this is like, what really is the diagnosis? Yes, she has moderately severe SN loss and moderate SN loss. It's not retrocochlear pathology. It is not auditory neuropathy spectrum disorder. So now only thing you can see here is the summating action potential, summating potential. If you look into SPAP ratio is 0.54, and she has fluctuating problem. So the next diagnosis that will come to our mind is saying it is Menial disorder. And if you look into the previous consultation, somewhere she was also diagnosed as having probably Menial disorder. But when I probed into the medical history, another thing that revealed was she has autoimmune disorder, and she's been consulting a rheumatologist for treatment. And she is under treatment with Polytrax, methotrexate, and Visaline for autoimmune disorder, and Vertin and Diamox for vertigo. So now with this, you would think that her hearing loss is because of probably autoimmune inner ear disorder. It is not really a primary disorder, maybe it's a secondary, because she does have other joint problem also she did have. And if you go into the diagnosis of autoimmune inner ear disorder, generally they say that you have one of the three, these major criteria and minor criteria, at least three of these major criteria and two of each of major and minor criteria a person should have. So if you go by these things, you can say that she does have bilateral hearing loss. There is a diagnosis of autoimmune systemic disorder. I didn't really look into the ANA or the T lymphocytes report, but the rheumatologist had said that all those are positive. And the other one is auditory recovery with therapy. I don't know whether her fluctuation in hearing loss is only because autoimmune disorder is also fluctuating. So whether it is fluctuating because of that, or did the medicine really make any difference? Though the mother reports that the medicine did not really show any improvement. So in fact, they discontinued the Polytrax and Visaline, they discontinued because it is not really showing any improvement in her. So, and of course, among the minor criteria, she is young, female. Those criteria are there. So we can easily say that it's most probably it is autoimmune inner ear disorder. And the other indications that are normally reported in autoimmune inner ear disorder are like fluctuating hearing loss. There are reports which say that there can be enhanced summating potential, action potential ratio. And vestibular symptoms are well reported, but what was really something striking for me was the poor word recognition score. I really looked into the literature to see what about the word recognition score in autoimmune inner ear disorder. I couldn't get many studies where they have done, though there is a ISHA report about autoimmune inner ear disorder where it says that the word recognition score is disproportionately poor. So the only question that came to our mind was saying that I did discuss, that's how actually this case got roped into here, because I discussed this case with Sandeep once before I made the diagnosis. Does autoimmune inner ear disorder really lead to synaptopathy? Is it leading to synaptopathy because of which there is such poor word recognition score? The next question that comes is now management. What do you do for the management? Hearing aid, she's been given a hearing aid and she had used your hearing aid, but she says that hearing aid does not make any difference to her. Like there is no improvement, absolutely no improvement with the hearing aid. So she does not want to use a hearing aid. We did not really formally do a hearing aid trial in our center, but she was old enough to report whether she's benefiting from a hearing aid or not. And all her speech understanding is only with auditory visual cues. So what is the next line of treatment you would think of for her? So cochlear implant, I did counsel her about cochlear implant, but only like few questions is like one the mother was very hesitant about going in for a cochlear implant because she does hear. She says cochlear implant is only for severe and profound when they cannot hear. Now she does hear, so does she really require a cochlear implant? My justification was saying that if she's hearing but not really understanding, and since the ABR is good, so she should benefit well with a cochlear implant, is what I would think. And only other thing is also like this autoimmune inner ear disorder is fluctuating. So if it is fluctuating, should she really go for a cochlear implant or will it really become better on its own? But in the right ear, the hearing loss has become stable. In the left, it started first in the right ear, then in the left ear. So right ear, it is really stable now, and left ear, it is fluctuating. So my recommendation is like saying maybe she can go for a cochlear implant in the right ear. She's not really made a decision, they're still considering. So truthfully, I wanted to present this case to take people's opinion as to what would you say for this? What do you think we can do for this child, for this girl? And so that's it in thing. And this is my team who helped me in testing. Swarali, Namita Bhatnagar, and Shruti. Swarali is an audiologist, and Namita and Shruti were students at Bharati Vidyapith. Thank you.
Thank you so much, ma'am. I'm sure a lot of us will take a lot of learning from this. You're a very interesting case indeed. I think it was a lesson that sometimes what looks very obvious and what seems to be in a certain pattern may not be necessarily the same thing. And it's very important to, make sure we look at the finer details and probe through proper history, and of course do proper diagnostic testing as well. So with this, we conclude all the talks for today. Now the session is open for discussion and questions. So I can see a lot of good questions in the chat. So let me start with some of the questions that we have. So the first question is for Dr. Pradeep. Dr. Pradeep, if you want to be online. I think the first question is about the coexistence of auditory maturation delay and auditory neuropathy spectrum disorder, and how we can we can sort of dissociate between the two. If you want to throw some light on that.
Yes, so this is one of the first experiences even I have where auditory neuropathy and maturation delays coexisting in the case when we did high rate and the regular ABRs. The previous cases where we had seen it was a typical case of ANSD where that progressed into auditory maturation delay. And in continuation to Shashank's presentation, we already had published one case on Lake's disease where we said that the ABR pattern, what we got at the time of evaluation was resolving ANSD. So I precisely, I don't have an answer of how we go about with this coexistence, or is it something which is going to be more common now? I have no answer for that. And in continuation to that, he is asked whether wave 3 or 5 may be seen in later. Definitely, I think if we monitor this child for at least next to 2 to 3 years, probably we'll start seeing changes in the ABR. Having said that, I have seen a case of Krebs disease or a syndrome where even at 7 years of age, the child still showed the same maturation delay what he had when he was 3.5 years old. So there are cases where we have seen or tracked the ABRs for 4 long years and seen no changes. And there are children whom we have seen at least after 2 years, significant changes. So my one-line answer would be it all depends on the underlying predominant neurological condition. Probably we may not have a blanket answer for all auditory maturation delays.
Thank you, Dr. Pradeep. The next question, I think, is also addressed to yourself. The question is in regards to the maturation of peaks in the ABR. So the question is that by what age do you think the other peaks in the ABR evolve? And what kind of intervention do you recommend for auditory neuropathy spectrum disorder along with auditory maturation delay?
I think the 2 questions combined. Thank you, Imran. The first one, I think I just answered. The typical answer for how long will it take to mature is something I think none of us can answer that, because it all depends on the underlying neurological conditions. Then if the neurological condition is treatable, non-treatable, if it is something syndrome, is the condition a non-syndromic neurological condition, as ma'am said, if it is an autoimmune disorder, there are various other cofactors which would really determine at what age this exact precise developments would happen. But definitely I have seen here, my clinical experience is once you see an auditory maturation delay, after 1.5 years to 2 years, we have seen significant changes in their ABR. On the other hand, there are patients on whom after 3.5 years also we have not seen significant changes in the ABR. So a blanket way of proposing that this is the cutoff age at which the ABRs would mature may not be a right way to do, especially with various neurological conditions. And the second question was diagnostic or intervention for ANSDs. I think Dr. Chandan spoke about it in detail. Rather than me repeating the whole thing, probably the auditory maturation delay, if you see a child with auditory maturation delay, and if we can track that ABR for next couple of months, at least 2 to 3 months, and if you see that there are consistent first peaks at least, and the child is hearing, probably as Chandan said, we can go, or Chandan sir said, we can start off with giving low gains at low frequencies and slightly higher gains at higher frequencies. This cutoff and all those things, predominantly it's a trial and error, and I don't see, and it is again case to case basis. I don't see that there is a uniform way of declaring that this is the line of treatment or this is the line of hearing aid fitting that we have to follow. Did I answer that question?
Thank you so much, Dr. Pradeep. Yeah, absolutely. Thank you for that wonderful talk as well. And I think that was the questions were really answered aptly. Now, the next set of questions are for Dr. Sandeep. I can see there are a couple of questions, but I think one of the questions, Dr. Sandeep, is in regards to the noisiness of the otoacoustic emissions that you talked about. So I think, like somebody has questioned that if the, internal bodily noises can affect the validity of the otoacoustic emissions, then how do we not know that every time we have a noisy OE recording, we don't need to probe any further to the cause of it, or something like what you presented could be the case?
First of all, if there is a noisy environment, OE recording is not going to be reliable. Okay, so you should not do. So that's the minimum thing that you have to do. You should record otoacoustic emissions in relatively quiet environment, preferably in a sound treated room. Otherwise, OEs are not going to be reliable. Now, if you have recorded in a quiet setting, yes, the circulation noise, breathing noise, the heartbeat, everything is going to be picked up by the microphone of the otoacoustic emissions. However, we are using several signal processing strategies, starting from using a nonlinear paradigm, using time-locked acquisition. We use averaging. We record otoacoustic emissions when we are recording. We record in the A buffer and B buffer. When we are recording TOEs, we record in A buffer and B buffer and look for the reproducibility of the response between the two buffers. So there are many things that are done to ensure whatever we are recording as OEs are actually valid otoacoustic emissions. So I don't think we need to doubt if it is recorded in quiet environments.
So
Sure,
Sandeep, one is the recording environment, and if the child is quiet. One is the room acoustics, and another is the child being quiet.
Yes.
So there is no audible noise from the child.
Sometimes the snoring, if the baby is sedated and if the baby is snoring, then we get similar challenges while recording otoacoustic emissions.
And one more thing that goes unnoticed is rubbing of the probe wire. So if it is dangling somewhere and it rubs against the cloth, that causes a noise which picks up into the noisy recordings.
Sure. Thank you so much for answering that question. I think the other question is for Dr. Shreyank. Can you explain the relation of posture or body position and otoacoustic emission recording? I think this question has been answered.
I'll take up that question.
Yep, I can see you've answered that question in the chat. Thank you so much, Sandeep sir. I think the next question is for Vanaja ma'am. Ma'am, the question is that if the patient were to undergo implantation, would the presence of Meniere's disease, if there was any, would affect the outcome?
I don't think Meniere's disease is not a contraindication for cochlear implantation. Actually, if the patient has to undergo cochlear implantation, another thing is we need to look into the ossification, because with autoimmune disorder, sometimes there can be ossification. That part of it, I think we need to. And in any case, I don't think this case had Meniere's disorder in it.
Yes, ma'am. There was some disturbance, but I think what I understood from what you said was that Meniere's disease is not a contraindication for implant. So even if there was Meniere's, we could have still gone ahead and helped her. But in this case, obviously, it was autoimmune disease, so it is a different case. If we can just mute our mics, there is some noise coming from somewhere. Thank you. There's still some noise coming. If you can just mute our mics, please. Thank you. I think that's pretty much all the questions that I can see in the chat box. I think a couple of comments were made for the presentation by Dr. Sandeep, but I'm sure Dr. Sandeep has noticed those comments and answered them. So thank you again, Sandeep sir, for answering them. I think one of those was that the condition that you presented could also be seen in some AICA loops and meningiomas and things like that. So definitely something for us to you know be aware of. But this was really a very, very good webinar, and collecting like such really esteemed professionals in the same platform itself was a big thing for us. Like thank you so much for helping us with this endeavor. All the speakers, I really thank you from the bottom of my heart to spend your precious time doing this, especially when you guys must be busy in your own things on a weekend. So thank you so much, and thank you so much listeners for attending this and asking all that interesting questions and making this a success. If you have any more questions, please feel free to email us, and we can always direct your questions to the speakers personally. Srividya ma'am, do you have anything to add?
No, Vanaja ma'am wanted to conclude, so I thought maybe she wants to sum up or something.
Yes, please, Vanaja ma'am, please go ahead.
Imran, before that, I just want to say that whatever I presented today, it was a teamwork. So the credit goes to the entire department of ISHA, especially Dr. Sharath and Dr. Vikas. Over to you.
I wasn't really planning to conclude, but anyway, first of all, let me congratulate Srividya and Imran for starting this case webinar, because I think everybody should view their case more in a critical way to see what we can learn from each case, because I keep telling the students also all the time, so every case we see there is something to learn, because it is not something I see or do pure audiometry every day. So if I do 10 pure audiometry, actually there will be 10 things that can be learned, because otherwise people will say, I only did pure audiometry, I only did this. So from every case you can learn. And this was really a nice thing to collect from different centers, different peoples and their experiences. And the case presented by Pradeep, that auditory maturation delay versus auditory neuropathy, or the case of Shreyank, really, I mean, those two really matched all one after the other. I think that was a good thing to say, that what we can learn from these ABR and auditory desynchrony part of it. And then how, I mean, Shreyank's case, anybody would have initially said auditory desynchrony, I think, if it had not really talked of mitochondrial disorder, and the importance of neurological evaluation for each and every case with ANSD, because that is another thing which everybody should remember, because a lot of times we say that, okay, it's OAE is present and ABR is absent, then it's ANSD, and stop at that. So importance of going further for the other evaluation is what it highlighted. And of course, Sandeep's case was very, very unique in its own way, where people later, I saw people commenting saying that I had also seen a case like that. And I think Deepa Valame and Chandan were saying that they had also seen similar cases. So I think what it shows is that we do see unique cases, but we need to share it and learn so that it becomes a good platform for all of us to learn. And Chandan's experience with ANSD was another thing which to show that, every day what we do is very important, and very simple things can also help us in doing good management. We don't have to really think of very complicated means to rehabilitate. Even with simple things, we can do good rehabilitation. Thank you, everybody, for attending this, and thank you, ISHA, for giving us this opportunity. Thank you. Over to you, Imran.
Thank you so much, ma'am, for such a nice conclusion. I think very aptly said. I think we must continue this case presentations and webinars in the future, so that we all can interact and discuss, in a healthy manner, and of course have some sort of constructive feedback as well, to deal with our own patients in our own clinics. So definitely a lot of help. Again, thank you so much to all the speakers, especially Sandeep sir, to be able to coordinate all this. You're very humble, sir, that you are saying that everybody is involved and all that, but we only did so much. But I think it was your effort and idea that prompted all this. So thank you so much, and thank you so much, Vanaja ma'am, Chandan, Saha sir, Shreyank, Pradeep. Thank you so much for all these unique case presentations. I'm sure there's a lot of things to learn for all of us from this. Stay tuned. We will have our next webinar, which will be equally interesting. We will shortly let you know the title and more details. So please stay tuned, and thank you for attending for today's webinar.
Imran, can you just take one more minute?
Yes, ma'am.
This is for all the audience. What I want to say is that all these presentations are not meant only for academicians or universities and colleges, because we do learn a lot from all clinicians. So actually, I want all clinicians to use this platform and present the cases they've seen, because it will be a good learning for everybody. So I think we should motivate all clinicians into this.
Absolutely, ma'am. I'm sure that we'll put this on the group as well, that whoever is interested, we can gather them together, and we can have some like-minded people present some more unique case presentations in the future. So we'll definitely look into it. So please, listeners, if you know somebody or you yourself would like to contribute, please come forward and let us know. We will be more than happy to coordinate for you.
Imran, can we end?
Yes, ma'am.
Thank you. Thank you, everyone. Thank you, speakers. Thank you, audience. Thank you, Imran.
Thank you, ma'am. Thank you, everybody.
Thank you, ma'am.